Welcome, everybody, and thank you so much for joining us for the Regional Policy Council event, Getting and Funding Mental Health Services in School. We're ready to go now, and let me begin by introducing myself. If I can get there, whoops, I advanced those slides too much. I am Debbie Plotnick. I am the Executive Vice President for State and Federal Advocacy at Mental Health America National Office, and I coordinate our Regional Policy Council. Our Regional Policy Council helps organize our affiliates all across the country, share information, and do grassroots and grass tops advocacy. It is run by four of our most experienced policy experts, and we have one of them here today. I'd like to begin, however, by thanking this year's Regional Policy Council sponsors. They are Alkermes, Janssen, MAPS, which is the Multidisciplinary Association for Psychedelic Studies, Myriad Genetics, Neurocrine Biosciences, Otsuka, Pfizer, Sage Therapeutics, Biogen, Sumitomo, formerly known as Sunovion, Takeda Lundbeck Alliance, and Teva. We truly appreciate their sponsorship. Oops, I'm afraid I went too far again. Can we end those slides, Jackie, please? Thank you so much. Today, I am joined by some wonderful people here in person. I'm joined by Ben Harrington, and Ben is the Executive Director of our Mental Health Association, our affiliate, Mental Health Association of East Tennessee. Ben is also one of our Regional Policy Council representatives and a board member of MHA National. We also have Karen Howard, and Karen is the Senior Director of Policy and Advocacy at Mental Health America. And joining us also is Stone, and she is the Senior Director of Children and Youth at the McNabb Center in Tennessee. We're going to begin today with my colleague, Karen Howard. She's going to give us an overview of what we've been seeing at Mental Health America nationally with regard to youth mental health. Karen?
Thanks so much, Debbie, and thanks everyone for joining. I will get right into it since I'm going to try to cover a lot in a short period of time. So we'll talk about data and factors that influence youth mental health, and then some federal opportunities in education. MHA's screening program sees over 10,000 visitors a day taking one of our 11 screens. And through that program, we found that youth who are struggling with their mental health are seeking support online more often than other age groups, with 38% of individuals in the US taking a screen being under 18. Rates of suicidal ideation were also highest among youth, especially LGBTQ youth of color. People screening at risk for mental health conditions are struggling most with body image or self-image and relationship problems. I also want to note that within 6 months of its addition, the ADHD screen surged in popularity, and most who take this screening report issues with starting or staying on a difficult task. Pew Research also says that academic pressure to be competitive for college is a factor. And just some additional data from CDC shows that in 2021, the survey of high school youth that they did indicated 44% felt persistently sad or hopeless in the past year. Over a third of students felt they were treated badly or unfairly at school due to race or ethnicity. And nearly 1 in 3 teenage girls seriously considered attempting suicide, up nearly 60% from a decade earlier in 2011. And you can see here, this is just how age groups compare in our screening program at MHA in 2023 only, this is the percent of people reporting suicidal ideation. So what's influencing youth mental health and what's different now than maybe 10 years ago? Well, first I want to take a minute to highlight figure 1 on the right, which is a graphic from the Surgeon General's December 2021 advisory on the youth mental health crisis, highlighting factors that influence youth mental health, and really frames that they're not only individual factors, but even more importantly, there are familial, communal, environmental, and societal factors of influence. And this really illuminates the public health perspective of mental health. Social media is number one. In a more recent report from May, the Surgeon General highlights social media as a big influence, and as does Pew Research. Mental Health America's Back to School Toolkit released in August includes information on media traps that many individuals think are unique to them, but are actually part of the design of social media to keep people online longer. In fact, some technology companies actually hire mental health professionals to assist in designing products that are intentionally keeping users online longer in ways that are compulsory and not voluntary. This is a tactic that has generated billions of dollars in revenue, including from youth under 18, who make up 1 in 3 internet users. Causes of harm are exposure to content online, including content that's hyper-focused on body image, exposure to online bullying, and inappropriate relationship with predators engaging in explicit behaviors. And then there are the physical impacts of spending too much time online, like losing sleep or other self-care habits, and having less time for in-person activities, which grow healthy socialization and attachment skills. There's also trauma, grief, and isolation that's increased. It's been made worse by the internet, but not exclusive to the internet. Exposure to trauma or traumatic content, including community violence, brutality, or self-harm, may be viewed at any time. And we have human losses from COVID. Estimates vary exactly how many, but there is agreement all over the world that at least over 160,000 children lost a parent or primary caregiver due to COVID. Do we have a system really set up to support connections to family, nutrition security, and housing stability? Finally, I want to note that the US Census released the supplemental poverty measure showing that child poverty has more than doubled in 1 year, going from 5% in 2021 to 12% in 2022, the largest 1-year increase on record. And this coincides with the expiration of the expanded child tax credit in 2021. Well, what do youth say that they want? They want to be involved in designing policies and implementing programs that impact them. It's the old nothing about us without us adage. Valuing and creating space for groups of students in policy creation and practice implementation gives students a stake in the game, and then they will be more inclined to ensure the system works and provide key feedback when a policy or practice is ineffective, so the system is continuously learning and improving. Additionally, MHA has found that before talking to an adult or connecting to a professional services, students have a strong desire to problem solve on their own and to help peers who are struggling. So we urge advocates to include mental health education, literacy, do-it-yourself tools, and other factors that are, or other services that are important to youth. I think that's my time cue.
Thank you, Karen. That framing is very, very helpful. I'm going to be joined by Ben Harrington now. Ben has an amazing program that has been around for 20 years that he has been running in Tennessee. Ben, please tell us about Mental Health 101.
Well, thank you very much, Debbie. I'm always happy to talk about one of my babies, if you will, because I actually started the program back in fall of 2000 at 2 schools in Knoxville, Tennessee, and it's now grown to serve 161 schools in 45 different school districts, 35 counties, and reach more than 33,000 kids in the past year. So Mental Health 101 is all about providing mental health education in schools to try to help young people, middle school age and high school age, to be able to identify and recognize mental illness symptoms, symptoms of suicidal behaviors, and also symptoms of extreme stressful events that they might encounter. We also work very hard to make sure folks understand the appropriate symptom duration required to be observed for that young person to intervene to help a fellow student. And, you know, usually clinically that can be like 2 weeks or more. But if someone is dealing with psychotic symptoms or suicidal behaviors, and we have to coach kids up to recognize that they can't wait 2 weeks in that type of situation. The last key component of the program is helping students build a important tool for their toolkit, and that is that list of trusted adults in their life, and make sure there are plenty of adults on that list in case someone's not available, or someone is no longer working at the school, or has no longer their church youth minister or something like that.
Ben, how are teachers and students receiving the program?
Well, it's one of those things that took off once we got started because of word of mouth. And so we often have a teacher who works in one school district who knows someone in the next school district over, and they tell them what they've been able to bring in. But in the state of Tennessee, to graduate from a public high school, a student has to complete a course called Lifetime Wellness. So that's our little gateway to get in, because PE teachers teach Lifetime Wellness in Tennessee. And you can imagine PE teachers are good at teaching, floor hockey and, relays and stuff like that, but they may have some subject matter that they're just uncomfortable with. And that's where an organization like the Mental Health Association fits in. We bring passionate instructors to the table, and we've got a huge team of mental health educators that we deploy 5 days a week to schools all across Tennessee.
Ben, tell us about some of the things that you discuss with the youth, some of the stressors that they might be encountering, they might be experiencing.
Yeah. So it's important for us to help a young person distinguish between stress, that's daily stress, very routine stressors in their lives, and what an acute stressor looks like. Because we know, Debbie, that the acute stressors, or ACEs, actually, the more you have them, the more of them you have incurred, the higher likelihood that you are on a path to developing a mental health condition like depression or anxiety, eating disorders, suicidal behaviors, substance use, that sort of thing. So we want to help young people figure it out. What type of stress is it? Is it an everyday stressor? Do they have poor coping skills? Do they develop better coping skills? All of that, because sometimes, stress is going to be the precursor of their mental health condition that they might otherwise develop.
Thanks, Ben. You mentioned ACEs, and for our listening audience, most of whom I'm sure are very familiar with it, it stands for Adverse Childhood Experiences. And these are things that happen to kids in their home, things they might be experiencing with their parents, with environmental factors, with various kinds of insecurity, the kinds of things that Karen spoke about, on top of course, what we're seeing now with social media. Ben, your program's been around for 23 years. You've expanded to so many school districts. Tell us about the outcomes, please. And tell us about the data.
Yeah. So the outcome is we have developed a pipeline of young people that are now seeking help, which is, the goosebump moment for us, because we knew if we changed what people knew about mental health, that it would make a difference. And so we now have young people seeking help both at school and in the community at community-based resources. So that's incredibly important. And one of the things that's of particular pride to me is one of our community agencies has seen a 450% increase in youth that they serve since 2010. And that's a direct result of our expanding the program from high school to middle schools. And then we, keep going to schools 5 days a week, 9 months of the year.
Well, I know you have some important things that link to putting those services in schools, which leads us to our next speaker, to Lindsay Stone from the McNabb Center, because her organization is doing those services in the schools with the young folks that are being trained and that are being identified. Ben, come back for 1 minute before we turn things totally over to Lindsay, and tell us about how the data is coming in. How are you looking at it both locally, and how is it feeding into national?
Well, there are a few different things. First of all, we do collect pre-test and post-test data. So we certainly know what that young person knows ahead of our teaching Mental Health 101, as well as after the fact. So that's incredibly important. The other things I would share with you is we do collect that adverse stressors data during our post-test, and that's helpful because we're able to have a distinct source of data on young people in Tennessee experiencing adverse situations, and that data is otherwise very difficult to come by, as you can imagine. So all of that helps us be able to paint the picture, help other affiliates across the country, if they want to start a school-based program, help them figure out what their data points are going to be. And then also there is a nifty resource at the national office level called the School-Based Services Community of Practice. And you better believe, because I've been doing this for 23 years and we've got a fantastic team at our agency, that our agency is able to support that schools-based practice community of practice team as well.
And we really appreciate your expertise and the fact that you offer a QR code to the students, and that helps feed into your local data and your national data.
It does, and we give every student something called a student mental health resource guide, and on the guide is a QR code. But also, interestingly enough, Karen mentioned the social media, other resources that young people want to dig into first before they seek help. And that information is in the resource guide too, because we know we've got to help fuel that young person along the continuum to change what they know, then explore other resources, and then get motivated to then seek help.
Thank you, Ben. Lindsay's going to tell us about how when young folks are experiencing issues in school, how the McNabb Center and their programs help serve their needs.
Well, hello. That was a great intro from Ben to kind of connect on what we're doing in McNabb Center. Like Debbie said, I have worked at McNabb for 19 years, and my first job was a school-based liaison. And I've been thankful that as I've developed and grown other programs, I've always had school-based services, which is really at the heart of what we do. And so I wanted to share just some really practical ways of how we've developed our services, our history, outcomes, and give you a little snapshot from McNabb Center as well. We've been doing school-based services since 1992 at McNabb Center. So we've had about 3 decades of really evolving and really seeing the need continue to grow from an early standpoint. So over those decades, we've done a lot of different positions, depending on funding, depending on the needs of the school. I've written behavior assessments for schools. I've been a counselor. I've done groups. I've done individual counseling, and it's really just evolved over the year. A few things that we've kind of kept consistent is that we want to be the bridge between home and school. So we don't just provide services from a school-based standpoint to the school system. All of our staff do home visits, community contacts, and really making sure that we're looking at every environment that the child is in. And we go year round. You'll see that kind of differently between other agencies that do school-based services. We just held really strong to your mental health doesn't stop during the or on the bookends of school years. So we want to make sure that we have those services year round. We've got a variety of different funding sources, and I'll kind of talk through how we've built partnerships quickly over the years. But really, since in the past 5 years, we've seen an increase with state funding with the Department of Mental Health and Substance Abuse Services in Tennessee. So we have a large, when you see SBBHL, School-Based Behavioral Health Liaison Services, meaning a master's level staff that's paired to 1 to 2 schools. None of our staff have more than 2 schools. So it's really an embedded person that can provide a multi-tier approach within the school system. When I talk about the tiers in a little bit, we really do mainly what we consider direct services, which are tier 3 services, really providing more of those outpatient therapy services within the school system. Students don't have to leave the school building to get their mental health care. Parents have less barriers on funding or transportation or access. And so we're able to provide that, and thankful to be in a state that really funds this program in all 95 of their counties. And so when I talk about that multi-tier support, we can provide anything from individual, family, group therapy, consultation, psychoeducation to student. We do psychoed groups. Ben talked about pre and post tests. Those are a part of that, so we can see the impact from those topics going out. Building that positive relationship between schools and family, like I talked about, that bridge support, really doing consultation and training topics for the school. We have 5 required kind of trauma-informed training topics that we do with schools every year, and do that a little bit heavier when we adapt a new school, and then kind of help schools maintain after that. But really from a trauma-informed lens, which I've seen over my past 20 years, I've seen that trauma-informed culture really grow as well. So right now, McNabb has those school-based behavioral health liaison services in 15 East Tennessee counties, which is growing by the year. It's incredible to see our reach even across the state at this point. But really from an access standpoint, to give you kind of a bigger frame point, we're in 54, or we have 54 school-based liaisons that are funded by the department that I mentioned. And those are spread across 65 schools in those 15 counties. But then we also have a pocket of direct funding from certain district schools. So I wanted to highlight a couple of those. For instance, Knox County has really come a long way in the past few years. And right now we have 35 liaisons funded directly by the district for every single middle and high school, meaning there's a 1-to-1 match of a master's level clinician in their schools providing support and really getting caseload referrals to be able to provide mental health support in the school. I like to say that they're embedded in the school just like a school staff. We want to be in our lane and do the mental health expertise, but we want to be embedded in that school so that it's normalized that we have mental health support in the school for anybody that needs it. Blount County and Maryville City Schools, just neighboring us, have 6 liaisons total between them, in addition to the department positions that are funded directly by the schools. And we're seeing a lot of the schools really prioritize funds, which is why I made the point about collaboration as well. I've come a long way in school-based services, and I will say we're at a good point, and there's a long way to go, but more collaboration, more support from school boards, districts, community members on really seeing the impact of kids. The school is the second primary environment of the child. Why would we not provide mental health support for them as well in that environment? And then a cultural standpoint, like a lot of that multi-tier support that I talked about that we do with our staff is really building that village around the child, making sure that teachers and staff know how to respond. Like we've already talked about ACEs and trauma, but really, how do we respond to mental health? How do we recognize it? How do we normalize it to take away the stigma that students can speak up and they can speak up about a friend? And so we've tracked a lot of data through the year, and I will say there's a lot of national outcome measures that we've kind of kept consistent through the year. For instance, like a reduction in behavioral health issues or referrals, improved attendance or stable attendance, improved grades, increased communication and cooperation between the home and school, creating that dialogue so parents feel supported, less restrictive academic placements, making sure that they're getting the right level of support when they're in school, and a reduction in juvenile court involvement and free from school suspensions, keeping them in environments that they'll thrive in, hopefully. And so this is just data that I pulled from last year. We saw 99% of students receiving school-based services from us that were free from juvenile court petitions. 99% of students receiving school-based services remained in their home, school, and community as opposed to inpatient or residential home treatment. 96% of students kind of kept their attendance good with no more than 5 absences in a quarter. And we've seen more access grow within the school systems and providing that support. And we've seen more training. We've not only in addition of the 5 training topics that we're required to do, we get a lot of topic requests for schools just to say, hey, can you come to a professional development day and train our staff on this, just to continue that culture of equipping them. One of the other unique things that we've done over the past year is really expanding and being creative when we get asked for grant recommendations or how to spread across dollars in the state. Again, with our Department of Mental Health and Substance Abuse Services, we received a part of the crisis intervention grant for the Tennessee Resiliency Project, and actually proposed to do a school-based crisis response team, which was really differently than we've ever done it. We've always kind of done the traditional outpatient embedded within the school, but this crisis response team is made up of master's level clinicians and bachelor's level care coordinators that are spread across what we consider Region 2 in Tennessee. So there's 16 counties that they cover, but they can do everything from crisis intervention, crisis consultation, referral and linkage for services, postvention if there's, for instance, a suicide, community violence, or some traumatic event that's affected the school system or the culture around them, that we can provide those extra counselors or extra support. They do training topics. They will develop a training around whatever the school needs as well, and really focused on, we know what the mental health need is there. We've got to be more creative about that and have teams that are available. We've gotten texts on Sunday night saying, can you be in our school assembly at 8 o'clock the next morning? That's what that team does. They're very mobile. They're on point for really whatever needs the schools need from them. And I'll end with just one of my favorite school-based quotes from a teacher that I've shared throughout the years that kind of summarizes what we do. But we think kids are behavior problems, or they're not interested in learning, or they're not able to learn, when really, when you get down to the bottom of it, there's just some experience that they've had that's taken priority over everything that's going on in their life. One of the things I love as we've diversified our funding is we've built partnerships, that all of this doesn't come easy. It's years of partnership building and an awareness of mental health needs, but we get to take that priority off the schools to say, we will come alongside you and the students and families to support their mental health in their primary support environments. And so that hopefully gives you a little bit of snapshot, and I know Karen's going to share some more, and we'll be ready for questions at the end.
Thank you. That was really wonderful. And the quote that you gave there was amazing. Before we turn things over to Karen, and she's going to tell us about some ways to fund programs. You talked a lot about your funding coming from school districts and grant funding. Have you used any of the larger programs like Medicaid funding or some of the other federal programs? And if so, did you have some difficulties there?
We do. I mean, like I said, you learn to be smart about it and diversify your funding. So when I talk about those direct services, like providing outpatient therapy, like we would in one of our carve out clinics in any of these counties, obviously if they have qualifying insurance, then we can build that from that environment to provide that service without them having to leave that building. So that ends up supplementing whatever we get for grants, and it helps us maximize our staff and make sure that we have even more support there. And so we're not totally dependent on grant or district dollars, but we will do that third-party billing, which is an understanding of all of those different contracts, that we will make sure that we do all we can to maximize those services. So yes, we do state Medicaid as well.
Great, thank you. I know some districts do, and some say it's just so much work, but Karen's going to tell us about some ways that is changing and about some other monies available. Karen?
I think you're on mute.
Thanks, Jackie. The Cardinal Virtual Sun. So I will just quickly go through this slide, which indicates that last summer, Congress passed the Bipartisan Safer Communities Act, which was billions of dollars in funding after the Uvalde school shooting that was appropriated through the Department of Education, the Centers for Medicare and Medicaid, and the Substance Abuse and Mental Health Administration. We know the strongest connection between mental health conditions and violence as suicide. Nevertheless, we think the package was a really good way to help support school-based services and multi-tiered services and supports, including universal promotion and prevention, education services, and there's even funding to support accommodations like excused absences or grace periods for making up work after a mental health sick day. All right, so opportunities to finance. I know this is a very ugly slide and would not be something that's designed and shared, but I wanted to get as much information on here as possible in case folks wanted to take a screenshot. The Department of Education shared that students are 6 times more likely to access mental health care when services are offered in school, and they have a new Raise the Bar initiative highlighting opportunities to support mental health in schools. The agency also recently announced its metrics or Mental Health Evaluation, Training, Research, and Innovation Center for schools. There's the Raise the Bar initiative. And the new metrics initiative will increase support and offer new resources for schools nationwide to train mental health professionals to provide school-based mental health services. It will support 2 grant programs in particular, the school-based mental health, and mental health services professionals grant program, as well as it will also distribute resources to states, school districts, and schools individually to help them implement high quality products and projects to address social, emotional, and mental health needs of K-12 students. The goal of the metrics is really to increase the number of school-based providers. And those 2 grant programs that are mentioned are the first one, the professional grant, which opened November 2022. So I'm kind of applying logic that it will likely open November 2023. That will be a grant for a partnership between a school district and a graduate mental health training program to train school-based mental health services providers for employment in that school district. And the goal of the program is to increase the number of diverse, high-quality trained providers in shortage areas. The second services grant, which likely will open in October, is a grant to state education agencies, so whoever's at the highest level in the state, to help with recruitment and retention-related incentives to keep school-based mental health services providers in the school system. And that can include promoting re-specialization and certification of existing providers for them to work in those schools. And it will also help with increasing diversity, cultural and linguistic responsiveness of school-based providers, including identity-safe services for students. They do have a note in the final rule that youth peer support specialists are able to be supported through this program as long as they meet the definition of school-based services. That brings me to the next section, which is on CMS. Oh, one quick note. Those 2 are the largest funded programs. However, there are also several other programs at Department of Education that states can draw down funding for, including for healthy climates, trauma-informed services, full-service community schools, and personnel professional development. If, students are experiencing problems, but school personnel don't know what to do about it, there should be some training and education that's funded by their professional development funds that can help those personnel appropriately respond, since students are really kind of saying that they're being dismissed or ignored when they raise concerns with staff and don't know really what their options are. At CMS, there's an incredible opportunity, and I will take as little time as possible as I can to try to go through what they're doing. So Medicaid covers nearly half of children, thanks to new guidance as required by the Bipartisan Safer Communities Act. There's no longer ambiguity about whether or not children can receive services that are Medicaid billable through schools. However, school districts and states need to now work together to submit state plan amendments to Medicaid for approval. These plans should align with the new administrative and claiming guidance and take advantage of flexibilities to expand mental health providers, including school psychologists or youth peer support specialists. And these plans need to really define that these providers are allowed to give services. In a 2020 survey of almost 2,000 young people seeking help through MHA's screening program, 44% of 14 to 18-year-olds stated access to support from other young people is one of the most important resources for their mental health. Additionally, ensuring telehealth is allowed through these state plan amendments can further assist students with access to services. Crafting new plans and amendments can be done with support from the new Technical Assistance Center on School-Based Mental Health Services under the framing of the Early and Periodic Screening, Diagnostic, and Treatment benefit, which provides for comprehensive preventive health services for children under 21 enrolled in Medicaid. And this is key to ensuring that there's a broad coverage and that plans are in alignment with goals of Medicaid. The new claiming guidance, and I will try to find the link. Here we go. Here's a link to that I will drop in the chat for you on this. The new administrative claiming guide clarifies how payments can be made for school-based services under Medicaid and CHIP, how states can simplify billing, including rural and small or under-resourced communities where care may be more challenging. It provides specific examples of approved methods that state agencies have used to pay for services and how to enroll qualified health providers to participate in Medicaid and furnish services in school settings. The new flexibilities on billing, documentation, and time studies are all things that states can use to adopt in their Medicaid plans, and states with approved plans that have already expanded coverage are Arizona, California, Colorado, Connecticut, Florida, Georgia, Illinois, Kentucky, Louisiana, Massachusetts, Michigan, Nevada, and more. There are some states that have pending state plan amendments, and there are some states that have yet to submit or have tried to go through the legislative process to approve services. If you do one thing following this webinar, I would say reach out to your education agency, your state education agency, and make sure that they know about tomorrow's webinar, the 28th in the afternoon, which the Technical Assistance Center is providing a space to go over the claiming guide and start giving assistance for submitting those state plan amendments. I know that was a lot, but I'll move to the next slide and we'll have questions at the end. At this time, I'd like to just give some really high-level recommendations for both affiliates of MHA and other groups that are working with young people who might be able to partner with schools or influence schools. We know the connection between, you guys are the missing piece of the puzzle. So we know the connection between learning, academic achievement, and basic needs. It takes feelings of safety, healthy connection, and emotional intelligence, as well as good stress for our brains to create the neural pathways that assist in focused learning and achievement academically. And you all must position yourselves to work in coalition or in collaboration with school districts, superintendents, school counselors, school psychologists, parent-teacher associations, and student organizations. Reach out to introduce yourself to these folks and let them know that you're also critical stakeholders in the education community conversations that are having. Elevate how your community-based work can complement theirs, because you are subject matter experts. They are not mental health experts, and you are, because you're hearing directly from folks on the ground and you're coming from the perspective of lived experience, which can oftentimes be missing. Ask states to ensure their Medicaid state plan amendments include what youth are asking for, what you're hearing on the ground, education, support, do-it-yourself services, and again, education. I'd also ask you to amplify young people's ideas in all of your conversations. As I mentioned, MHA's screening website, the largest demographic coming to take a screening are under age 18 years old. They keep saying that they're not ready to connect to services yet, but they do want more education, knowledge, information that they can use to help themselves. They do want to be able to help their peers. About 1 in 2 youth are seeing trouble in their peers. And they want to be able to help. There's also a note about using language that can be considered nonpartisan because we don't want to alienate anyone in the conversation. And there certainly has been in the last couple of years parents' rights groups and other groups that really want to elevate the voices of individuals. And what we know is terms like social or social emotional can sometimes be a turnoff for them. So oftentimes we say life skills instead of social emotional. And that's a way to ensure that you're keeping folks' ears open no matter who's in the room. These social emotional learning skills or life skills are useful for everyone, whether you're in a red state or a blue state, and mental health is important. And then finally, one of the principles from MHA's 2021 Youth Policy Report on school-based services was we don't really need to recreate the wheel, but we do need to build on top of what exists. And what exists is some states and school districts are billing for Medicaid, but they're having to blend that funding, as Lindsay mentioned earlier, with other funding from different sources. If Medicaid is billing for more services through state plan amendments, then that frees up more education dollars to do the engagement with young people to help them with having a leadership role in creating policy, perhaps even providing transportation for a student if they stay at school longer and don't have a ride home, to help with planning or crafting a school mental health policy or a plan for what happens after a student needs to take a mental health sick day, what supports are in place when they come back to the school. Having convenings and supporting youth in elevating their voice in those types of conversations is something that you all can really do. And if you're looking for ideas, there's a really cool resource that I'll drop in the chat as well. That's about what I'll start with, and appreciate your time today. Thank you so much.
Thank you, Karen. That was an amount of information. I invite everybody back on screen. Thank you. And I want to invite our participants to please put questions in the chat, and we will direct them to our experts that we have here. I've got a couple questions I'm going to start with. Karen, since you just finished, let me ask again, Medicaid. I can see that opening some doors, although there's still a hoop to jump through with putting in the state plan, will help a lot of students and a lot of schools get money that they have not been able to get through grants or through their school districts, as many of the districts in Tennessee have been able to get. Can you talk a little bit about what would be necessary for the school districts, in addition to putting it in their state plan amendment, what they have to do with respect to the students being on Medicaid or not being on Medicaid?
That was for me, Debbie.
Yeah,
I'm sorry.
It was. It was for you.
If a student is on Medicaid.
Yeah, about the schools, about whether or not, schools have, if they have a lot of students who are on Medicaid, they can bill for those students. But some of the ways that having embedded people there at Medicaid by more students being able to bill, that would allow the kind of thing like Lindsay has in Tennessee, that you have staff members who could not only serve students on Medicaid, because of course you can only bill students who are on Medicaid, but persons in there. Do you know of any other ways that opening those doors to those Medicaid dollars of assistance to school districts and getting more services across the country?
I'm sorry. I lost you towards the end of the question.
Oh, I'm sorry. I was just thinking about how a new influx of money will make a huge difference across the
Sure.
country if you had thoughts on that.
So the additional ability to bill Medicaid will free up other education agency dollars. Those dollars can be used for various resources or services or just general opportunities for changing how a school operates. For instance, there's a school district in Washington that trained all of its bus drivers and gave them additional kind of background about the importance of greeting each student by name when they walk on the bus each morning. Well, they saw absenteeism and tardyism decline, and all students made the bus for the rest of that semester. These are small things that can help to support climate and image and mental health that can't necessarily be billed to Medicaid, but education dollars can be used for.
Super. Thank you. Ben and Lindsay, you've talked a lot about collaboration. Tell us a little bit more about how that's worked in your school districts all across Tennessee, please.
Lindsay, you want to go first?
Sure. So I think it depends a little bit on the district and how long we've had a relationship or been embedded in that school. But for instance, a lot of our districts, we have monthly calls and we're talking about what needs. We're sharing grant opportunities. If an educational agency has to be the lead, can we partner? There's lots of that conversation going on throughout the need. And, similar, I think Ben mentioned it earlier, a lot of like word of mouth of like, oh, I heard this school system had this, or I heard, your TRP team came over here. And then school systems get curious on how they're funded or how we're embedded within the school. So a lot of those collaboration talks sometimes start from hearing something that we're doing in another district. That's more at a global level. We just kind of keep those relationships going to make sure that we partner on the district level, but then collaboration with our staff within the schools, really goes between, I always say, like, our staff should not be in an office pulling students all day and never talking to teachers. They're embedded in that culture. So they should be in kind of whole child meetings to just talk about maybe referrals to them or an output of, what we're working on in a safe and confidential way. So there are pockets of collaboration that we really want our staff to engage and collaborate with those schools on the school level. And then there's responsibilities for me and our leadership within our center to keep those partnerships going with the school districts and making sure that we're adapting what we're providing to what the school needs and really sharing just from a needs perspective. We do a needs assessment with every school at the beginning of the year to say, hey, what you needed last year, I'm sure probably a lot of it is to work directly with students, but maybe there's another topic that they're like, we were drowning with this topic with students last year. Can you please provide education on that? And so just keeping that conversation going, I think is a big part of what we do.
Debbie, to
Ben?
answer your question, one of my favorite stories from Mental Health 101 is when a senior official at the school district in Knoxville at the time contacted me and said, hey, Ben, we got a problem. We've got a family who needs to get their child into therapy right away. She's been cutting and she can't find a provider. What do we do? And so I was able to put them on hold, get with the medical director at one of the treatment providers and broker same day service to see a therapist and get that started. And that's the sort of thing that can happen when you've got an organization like ours that's been around 75 years. We know everybody, and we're able to pick up the phone and make stuff happen. And that's the collaboration that works. And then beyond what Lindsay said, it's working with the school districts every day, in coalitions, that sort of thing. And when they started to think about, well, how do we move forward with putting mental health services in schools, then it's easy to say, well, you got certain partners that I would start that conversation with and see what they can do. Can they just visit once a week or every day, or they want to embed somebody at the school? How's it going to work best? Because we do know if a child is referred out and mom and dad picks up to take that child to the therapist, they're not coming back that day. So that child loses that learning opportunity, and it's a crapshoot as to whether that child actually gets to the outpatient service anyway. So it's much better to embed that service in the school.
We've got some questions coming in from the chat, and one of
There's
them.
one I'd love to answer.
Oh, sure, Karen, go right ahead.
So with respect to Karen Martoglio's question about community mental health centers and working with MHA affiliates, I wanted to encourage an MOU or other agreement between the mental health center or the school district, so that your organization can be someone that they refer to or offer services through. You could potentially receive some of the sub-billing from the mental health center, or you could receive some funding directly from the education budget of that school district or school. And you might want to start with a conversation with the superintendent or other kind of school board leader about that, because they want to be working with community-based organizations and don't really know how to reach out or where to go.
That was just the question I was about to ask. Thank you for answering it. Very, very helpful. We've got some other ones that have come in from the chat. People are asking about whether or not services, I assume these are right now for Tennessee, but also, Karen, feel free to answer nationally about whether it is for K through 12. Or if it's starting a little later, how that varies and things like that. We just saw an amazing amount of information. Ben was very on top of things 23 years ago. Understanding middle school was the place to start. Now we're seeing through our screening almost as many really younger children, 8 to 11, coming in. Feel free, anybody who wants to jump in to address that.
I would say most of our dollars have focused on K through 12, but a lot of we have a community school initiative in Knox County as well. And some of those schools have pre-K programs, and we're able to take those referrals from a pre-K standpoint too, if they're zoned for that school. So we definitely have a pocket of that younger population, or if we know that they're going to be a rising kindergartner, sometimes we can engage them early in the process, or if they have a sibling that we need to address, those types of things. So there's some flexibility around that. But most of when I talk about school-based liaison dollars, they are focused more on K through 12.
Lindsay.
I do know the Bipartisan Safer Communities Act had some additional funding, I believe, for Head Start programs. I'm not sure if you're affiliated with them, but there may be some additional funding as well for billing for pediatric services, so that can be as young as 0, I guess. There are some efforts, but not as significant amount of dollars. So there's still some advocacy that needs to be done on the earlier side. And for parents who are looking for support, there is it's named the Maternal Mental Health Hotline, but it helps both fathers and mothers or birthing individuals and their partners in any mental health issues that they might be experiencing, which they also provide support for the child at that through that hotline as well at HRSA.
Thank you, Karen. Lindsay, there's a question for you. And Karen touched a little bit on this as well about the clinicians. Are they always in person, or sometimes are the services offered by telehealth?
So more of our traditional approach, all of them are in person because the students are in person for the most part. There's still a small pocket of virtual. And so I'll talk about how we've addressed that too. They are all in person. So they show up to the schools every day. That's really more of their primary work environment than the McNabb Center because that's where they show up to every day. So in person at the school, we don't do, now we can telehealth a parent in if we feel like, hey, we need to do a family component, that we're responsible for that when we pull a student, that we could make that a family session and maybe do a telehealth with a parent in if that works for their schedule. We don't do a lot of, or really any telehealth from me in my office to telehealthing into the school because it requires pulling a school staff to be with that student or at least close to them to supervise them. And the logistics of that have just, the resources have not been there to do it that way. And we prefer to be in person. It's just that's just best practice. We did over the past year do a specific student telehealth contract with Knox County to provide student telehealth for those that may need a non-traditional hour approach. So late afternoon, evenings, and or weekends. And so, and that would also meet the need of a small pocket of virtual school students that are in attendance. And so we've done that in that format, but our primary is in person.
Great. Lindsay, I know you earlier said that you continue services year round, you cover the summer. One of our participants would like to know, how do you cover the services during the summer?
Sure. Well, I always say we don't change the service. We may just change the location. So sometimes they come to our office, depending on if one of our outpatient clinics is closer to their school. A lot of the schools are still operating programming and or principals and admin are working in the summer. And sometimes they'll let us have our same office just for that continuity of the student. And if that's closer to their home, if that school is a mile down the road versus coming 15 miles to our office, we want to give them that access point. We do a lot of home visits or family contacts within the summer. And we can do telehealth during the summer a little bit more freely depending on the preference of that family. But it really is just adapting to the environment and the schedule of that youth in the summer.
Great. Thank you. So important that one of the things we at MHA National are working on is keeping the expanded telehealth coverage and services that were available under COVID, under the public health emergency. And we are really seeing lots of ways that for school districts that don't have the in-person embedded or that need that can really make a huge difference to getting services to more people. Any last remarks that anybody would like to offer, or last advice for getting more services into schools?
Well, Debbie, you know I'm not going to be bashful. So
No.
what I would want to suggest, folks, if they're going to be advocates in their community, they've got to pitch their school leaders and community leaders and parent leaders and student leaders on one fact, that school-based services, school-based mental health services are like that four-legged stool we hear about. You got to have a leg of the stool that is student type services, and that would be what we're doing regarding mental health education in schools and student-led initiatives. The next leg would be teacher initiatives. What are we doing to prepare the teachers so they don't look like deer in the headlights if a young person says, hey, I need help? The third leg of the stool is the supports for parents, whether that's working with the PTAs or PTSOs, preparing them so they don't look like deer in the headlights. And the last leg of the stool is mental health services. And those are going to be services at the school. How are we going to do that? How are we going to fund it? How are we going to refer to them? But then also, lastly, we can't forget about expanding mental health services in the community too, because a therapist at a school can only see so many kids during the week. And so there will need to be some overflow in the community to help out too. So that's my best advice.
I want to thank everybody who joined us today. We are recording, and you will receive a link to listen to the recording. You are most welcome to share it. And please join us again for all of our Mental Health America webinars and for our regional events. We have an in-person meeting coming up in December. Thank you again, and thank you to Ben and to Lindsay and to Karen. I hope to see you all soon. Thanks. Bye-bye.
Thank you.